Good evening, everyone. I am thrilled to be here. I am Lauren Gates, your host of tonight's Airway Health Solutions conversation, featuring the wonderful, marvelous Dr. Maryam Motlagh. I'm so excited to have her here and on faculty. So we're going to have a great evening. This conversation was actually put together just a couple of weeks ago from a lot of demand from the conversation you had on the Dr. Mike DeLuke on the Doc podcast. And we just wanted to kind of continue that momentum. So tonight's topic is why good restorative dentistry fails, TMD Airway, and designing long-term success. So thank you, everyone, for joining us this evening. It's going to be a fabulous evening. It's all about general dentistry and comprehensive care. So for me as a dental hygienist, I feel like I'm digging in and getting back to my roots, getting back to comprehensive dentistry, which is always exciting for me. So on behalf of myself and I want to welcome everyone this evening. We do have a lot of attendees this evening, and this will be available for recording, so you can share this with your colleagues. This is going to be a great lunch and learn or team huddle to share, come Monday morning. So we're excited to have this as a resource for everybody. So I always like to see who's with us this evening. So let's just take a quick poll, and then we will go ahead and introduce Dr. Motlagh and give her the floor. So let's see who's with us tonight. I think it'll be dentist heavy this evening. I believe they're going to be in the forefronts. Let's see. Okay, so we've about 50% participated. Okay, we're going to give it a couple of seconds. And we apologize if your profession isn't listed. We only have so many options. So, okay, let's end the poll now and see what we got. Okay, so the dentists are going to leave it as close. Hygienists are at 39%, dentists at 41%, pediatric dentists on board, myofunctional therapists, SLPs. Welcome, everybody. All our other, we're thrilled to have you. And Dr. Motlagh, before I give you a formal introduction, why don't you just share with us, why you're excited to share this topic this evening too, because I know it's near and dear to your heart, just a kind of an overview of why we put this together.
Yes, that sounds wonderful. Thank you for hosting me tonight. It's wonderful to be part of this community. Well, like many of you, I started as a general dentist, passionate about doing smile makeovers, especially like 25 years ago when we had that extreme makeover show, and I was doing my own share of smile makeovers and really changing lives and confidence in my patients. But what I noticed that it was that these smiles were not lasting. Beautiful veneers broke, and patients started grinding and clenching after restoration. So I started digging more into occlusion. I was suffering as a patient from TMD myself, and I started looking at the connection. And 25 years later, I'm still a student. I'm still learning new things. I started as in CR dentistry, and then I also looked at muscles, impact of the muscles, and I now can see airway and how everything is coming together in a more physiologic approach. So I wanted to share my failures, and my success with my colleagues, and just set a better standard of care for our patients by paying attention to other contributing factors.
Well, we're so grateful to have you this evening and look forward to your presentation. Just a few housekeeping items I want to run by before we get started. A few disclaimers. The views presented are the opinions of our speaker and are not necessarily affiliated with Lauren Gates and Associates and Airway Health Solutions. And the following webinar is provided for educational and informational purposes only and does not constitute providing medical advice or professional services. The information provided should not be used for diagnosing or treating a health problem or disease, and those seeking personal medical advice should consult with a licensed physician or dentist. Always seek the advice of your doctor or other qualified health provider regarding a medical or dental condition. And then lastly, we are proud to provide free CE this evening. So in order to receive your CE certificate, you must be in attendance for the entire program, and our Zoom software does track the attendance, so we do not need a code or a survey. And we also love to give our free raffle at the end. You need to be present you gotta be in it to win it. So tonight we'll be spinning the wheel for our Pediatric Airway Health Fundamentals course. So that's all covered, and we're excited to be here. And I'm just gonna give you a formal introduction because you have such a wonderful journey that I'd love to share it with everybody who may not know you yet. So Dr. Maryam Motlagh is a general and cosmetic dentist based in Portland, Oregon, with distinguished focus on TMJ, TMD, airway health, and holistic functional dentistry. She graduated with honors from Oregon Health and Science University School of Dentistry and pursued extensive postdoctoral training at prestigious institutions, including the Academy of Cosmetic Dentistry, Spear Institute, Las Vegas Institute for Advanced Dental Studies, and the Epigenetic Orthodontic Program under Dr. Dave Singh. As a fellow of the International College of Craniomandibular Orthopedics, Dr. Motlagh developed and patented the MyoAligner, an FDA-cleared non-surgical appliance for treating TMJ disorders, migraines, and jaw misalignment. Her work emphasizes a multidisciplinary, non-invasive, and bioremodeling approach to treating occlusion-related disorders. She leads an active practice in Portland, engages in speaking and education efforts, and aims to empower general dentists through innovation and hands-on training via the MyoAligner Academy, and now Airway Health Solutions is proud to have her as faculty. So Dr. Motlagh, I'm going to give you the floor. Take it away, and let's and dive in all about comprehensive care and why good restorative dentistry fails and what we can do about it.
Yes. Why does good restorative dentistry fail? Many of us dentists are perfectionists. We learn perfect crown margins, perfect shade taking techniques, carving secondary anatomy in our teeth. But sometimes we fail to look at the bigger picture. We have such a micro view of what we are doing that by not looking at the whole picture, how this patient is chewing and functioning and breathing, our dentistry, our beautiful dentistry can fail. So what I learned in my career is that by paying attention to the whole patient, the whole body, we can really increase the longevity of our restorations. So some of the key objectives that I wanted to focus on the next hour was the intimate connection between airway, TMD, and occlusion. Many of you here being part of Airway Health Solution, I know you understand the impact of airway on our adults' oral health, and how, with orthodontics, we need to go ahead and just have it in mind that we can improve this patient's airway and tongue size and basically tongue room and space in the mouth so they can function better. There's a big connection between oral occlusion and TMD. Basically, the way that our upper and lower jaw come together is through the teeth, and when the alignment of the teeth can change, obviously our jaw position will change. Condyles can be out of alignment, TMJ disc can be out of alignment, and as the mandible changes position, our airway can be impacted. Mandible is just suspending from the muscles from the maxilla, and the only way that these two bones come together is through the TMD and through temporomandibular joints and through occlusion. So occlusion plays an important role in basically the orthopedic alignment of our head and neck. And and this is just the anatomy. Now the way this patient functions, the way that they press the tongue either in the roof of the mouth or on the side or anteriorly, it just really makes a difference in the orthopedic alignment, in the way the muscles function, and basically the health of the airway. So my hope is for you to be able to identify these candidates in your exams. And what I really want to emphasize on is a comprehensive exam. If you just take a little bit longer, maybe half an hour longer in your exams, and pay attention to signs of TMD, which can be a whole list of 20 items that can show you that this patient might have a pre-existing condition. Because about 86% of population has malocclusion, but not everybody complains of pain and discomfort. We have about 30% is the prevalence of TMD in adult population, and about 11% of children suffer from TMD. So you can have a lot of malocclusion but not have the symptoms yet, but that doesn't mean that problem does not exist. And if us as providers, we don't identify that first, then if anything goes wrong, it will be our responsibility and our liability. So to protect ourselves, to protect our practice, We need to gain more knowledge in this field, understand the signs and symptoms that the patients are asking. And sometimes squeezing that information out of the patient is not easy. How many times have you seen? Just yesterday, I was just about to start a procedure on a patient, and I saw some swelling in his ankle. And I asked him, he said, "Oh yeah, I have a big rod in my leg," but he never told us that. I'm like, "Oh my gosh, we have to do prophylactic antibiotic for you. You never told us that." Patients don't know that the little itching in their ear or the tinnitus or vertigo can be related to an undiagnosed TMD. And if you're putting 6 veneers on the front because the patient's teeth were worn down and now the patient wants a beautiful smile, by changing the height of those teeth by just 1 millimeter, you can get yourself in big trouble and cause a lot of sensitivity and discomfort in that patient, because now you're invading their occlusion, because or their path of closure of mandible, basically. The sensitivity of the bite in the anterior segment of our mouth is about 14 microns. So and that patient is used to opening and closing their mouth in a certain trajectory. So if you just add 1 millimeter, 14 microns versus 1 millimeter to those front teeth, to give them a prettier smile, we can really get in the way of their mandibular closure and trigger TMD symptoms that we're hiding. So, it's taking that half an hour extra time. And if you cannot do it in hygiene, have the patient come back, go through the signs and symptoms. And, when we have time, I'm going to take about 2 hours to go through all the signs and symptoms that you need to ask for the patient and document. And, I'm not saying that every case will end up being full mouth reconstruction, but at least you have documented it, or that, maybe after the placement of these veneers, you have to put this patient in a mat device to protect your veneers at night from grinding and clenching, or, that because a lot of them are trying to open their airway. A lot of the protrusive wear pattern that you see, like shown in this picture right here, you can see they're just making a veneer to one tooth. How many times do we see that to one front tooth? You can see a moderate to severe wear on the adjacent teeth, on teeth number 7, 9, and 10. But the dentist is making a big, thick crown, and that patient is going to reject that crown, or they're going to bang on it so much that the tooth will end up needing a root canal or might crack. So, when we are looking at more of a comprehensive approach to dentistry, we're going away from single tooth dentistry, being mechanics of a tooth, to more like a whole health approach, to more doctors of the oral cavity, and doctors of the mouth and head and neck, because the connection of the head and neck and the mouth is just so intimate. So identifying these candidates in your practice is the best thing, and that the only way that you can do that is not to rush through exams, and just take some time, and at the end of the day, you can see that your dentistry will last longer, your communication with the patient is better, and you won't have any headaches, in the practice with patient complaints and going back and forth for adjustments and complaining of pain. Dentistry can be very rewarding when you plan things right and execute them right. And then I like to talk a little bit about integrating a physiologic workflow into the practice. Again, starting with signs and symptoms, maybe running some diagnostics. If you suspect sleep apnea, having a home sleep study done, or referring the patient to the right provider to have the sleep study done. That way you have some good diagnostics when we start. We will never operate on a tooth unless we have an x-ray. So how can we just change somebody's occlusion through ortho or restorative dentistry without looking at muscles, without looking at their jaw alignment, without looking at their airway? These are all huge contributing factors that really help with the longevity of your restorations. So in the next few cases, just to kind of like put a visual to what I'm talking about, I'm going to share some of my cases with you. And as Lauren mentioned, I developed my aligner because of years of being in this field, coming from a restorative background and also understanding airway, understanding the importance of devices. So I developed this device that has worked very well in my hands, and that's why I'm sharing it with the world. So this is kind of like how I use my aligner in complex restorative case. Now this case was complex to me, but to the previous dentist, because she didn't do the right examination, was not a complex case. This patient actually came to me because he had recent veneers done on 8 and 9, and he's a top executive in Vegas. He can afford to go to any dentist. He went to a cosmetic dentist and had the front two teeth and the opposing two teeth veneered because they were severely worn down. Well, the reason he called me is because his sister referred him to me. He had gone twice, and those veneers had broken, and now he had the opposing tooth broken and in temporaries. So he thought he was getting some simple cosmetic dentistry. His dentist thought that she's just slightly changing the size and color of those front teeth to give him a nicer smile. But they got in trouble. I think all of those restorations were replaced twice, and the patient had to refund him. This is just not a good experience, neither for the patient and neither for the dentist. So he came to me basically because 8, 9, and 24, 25 were breaking. Well, most of you that are in this field, you can just see that by looking at the alignment of this patient. Orthodontically, this patient has issues. He has underdeveloped upper jaw, retracted mandible, a severe bite. You can see that there's a lot of problems in this mouth. And when I started to ask him about his sleep quality, it wasn't very good. So I started taking CT scans. So before I give him a diagnosis, basically, I wanted to make sure that I understand his signs and symptoms. One of the big things that I found out was that he had sleep apnea. He didn't know, but we tested after he gave me the indicators, and then we went ahead and tested, and he had moderate sleep apnea. So, and then but he didn't complain of any pain. He had no jaw pain, nothing. He just wanted to fix his front teeth. So by playing this video, I can show you that when after I did my diagnostics, my CT scan, I do some computerized jaw tracking. I look at the muscle activity. So physically, I look at the joint position, and I also do other diagnostics to see how he's functioning, how he's opening and closing his jaw, how much range of motion he has, how strong his muscles are, how relaxed the muscles are. So using all that diagnostics, this is the bite that I came with. You saw that gap, you saw the opening. Now, everyone, there's different variety of methods that you can establish a construction bite. There's CR method, neuromuscular. There is, the different ways that you can come up with a proposed bite alignment basically for your patient that takes them away from this pathological bite position that is causing problems. So with my diagnostics, this is the relationship of the maxilla and mandible that I came with. And to duplicate an occlusion in this position, I had to do a 3-segment myeliner on the bottom and a 2-segment on top. I didn't cover 8 and 9 because aesthetically it would have looked really bulky and big. So this is kind of like where I test drive the occlusion before I prep a single tooth. This is completely reversible. Now, I used to do this. There's different ways. I used to do it with an orthotic. So once I came up with that intraocclusal space for the ideal relationship of the maxilla and mandible, I went ahead and I used to just put a full arch clear orthotic. You can do that. You can have the patient tested. They get quite a bit of, if they have TMD symptoms, and as long as you achieve the physiologic rest position and relax their muscles and have the joints in a nice CR position, and if they're comfortable in that position, then that makes you then gives you more confidence to go to the next step. So you can test drive this position with an orthotic. Most patients cannot chew and function with an orthotic. That's why a lot of physiologic dentists use fixed orthotics. So they do a diagnostic wax up. That's another way that you can do it. They do a full arch diagnostic wax up. Then using a stent, they will go ahead and basically make a full set of temporaries or onlays to place right on top of the teeth. We call that a fixed orthotic. So I used to do a removal orthotic with kind of like acrylic, then use a fixed orthotic on the teeth. And with that, then patients could chew and function, so I could test drive their bite before I prep the teeth. And then I would do an upper and lower full diagnostic wax up. So, but, and I tried that for many years. It worked, but it was really a lot of clinical time because each orthotic needed a few adjustments and equilibration. So it ended up costing me more in lab cost and also chair time. So that's why I came up with this solution. Basically, I'm using the myeliner. It's to use it both as an orthotic and my temporaries. So patient came to me, as I said, he was from another city, came, had this done, had this delivered. I checked him the next day, did a little bit of a fine-tuning equilibration on the orthotic. And usually I keep the patients in an orthotic position for about 3 months. A lot of research has shown that it takes about 3 months for muscles to calm down, for the joint position to settle, kind of like some healing and bioremodeling. And after that, I can go to the phase 2, whether it's restorative or orthodontics. In this case, it was orthodontics. So you can see how I can stabilize the bite, patients chew and function with it. Sometimes I use a temporary cement and I cement it on the teeth. And I think in this case, I use it for the top. On the bottom, because we were able to design all the way to the gum line, I had the patient just do it as a removable device, but they can chew and function with it. And then if the patient doesn't have enough retention, they can use like a chairside or over-the-counter adhesive, like a denture adhesive. So in the next phase, when I'm ready for full mouth reconstruction, then imagine you're doing one tooth. We take a template, basically, of these temporaries or the myoliners, and as I prep, I can either do it in segments. That's another thing. With the segmented design, you can remove each segment and capture your bite. You can either do it with physical impressions, upper and lower, and then keep relining this bite registration. I do digital, but I like to have a backup as physical, just in case my computer crashes. So once I have the bite adjusted and equilibrated, before I even start my full mouth reconstruction, in the 3 months, I have the bite adjusted. So that is basically my pre-prep occlusion. I'll bring the patient in, scan the upper arch, scan the lower arch, with myeliner. And then as I'm prepping, I will remove it. And then I have my bite scan too, upper and lower bite scan too. So that gets stored in the computer. So as you're removing old crowns and prepping teeth, then you can just continue your scan your preps. You already have your bite, but I would highly recommend doing the bite registration too, just to have as a backup. So, or you can do it in segments. You don't have to do full mouth prep in one appointment. It can be hard for a lot of patients. It takes me about 4 or 5 hours, but it can take up to like 8 hours. And I used to spend a lot of times making temporaries. I think at least the last 2 hours of my appointments were making the temporaries, but I'm now kind of like lowering it to 5 to 10 minutes, because then I can just park the myoliners that have already been equilibrated. He's already been wearing them. I will just park him basically in my template and then reline it with some temporary material. So you can see, actually, I'm showing you that right now. It just goes in the mouth and he bites down. So the only temporaries that I actually made chair side were 8 and 9, and you can see how they're kind of like tipped in. In our mini residency course that we have coming up, we're going to follow this case step by step, with the right forms, right consent forms at each step. We're going to show you how you can just make a complex case like this very simple. A lot of you do orthodontic application, do expansion ortho. This is one of our cases that Dr. I believe Tenen and I did on this case. So she had expansion done, and you can see there's spaces that are open for premolars, beautiful spaces open after palatal expansion and ortho. But these patients, they wear down their teeth at different rates. It could, if they have like a crossbite, they can wear a canine all the way down. They can wear those good functioning cusps down. And no matter how much ortho movement you do, you might not be able to achieve ideal occlusion. And so sometimes these patients actually need to be finished with phase 3 restorative, similar to this patient. You can see she's lost a lot of height on the upper and lower. Her mandible also retracts a little bit during the day because she just doesn't have enough vertical dimension. So TMD symptoms were flared up a little bit even after ortho and expansion. And this was just a very easy way for us to test drive that occlusion and make sure that the patient is a good candidate for it so they can chew and function. So this is another way that I use it after my ortho. And, not a lot of patients can afford expansion, ortho, restorative, all, back to back can cost $100,000. So if you kind of like phase it out and buy them some time with these, then it makes treatment more affordable for them. This is how Dr. Merchant, one of our providers, used the myoline for almost 3 years on this patient that was medically compromised. She needed, you can see how that patient is struggling with the tongue space. In that position, she hasn't been ignoring teeth. She has almost every single tooth except those 4 anteriors crowned and restored. But the structure, again, back to that structure, the whole structure was never looked at. I always use the example of alignment in the car for my patients, and I tell them, if the alignment is not good, your tires are not going to last you long. And that's exactly what we're seeing in these cases. Patients are breaking the teeth at the gum line, crowns are failing. And you can see actually many of them have broken at the gum line, and the crowns probably outlasted the roots in these cases. But this is basic. This is simply a patient that has airway issue, functional issue. They need that vertical opening. Dr. Merchant stabilized this patient. And at this point, you can very quickly make a cheap mat device for them. So to open the airway, help with their CPAP. So there's different ways that you can stabilize these complex cases. We are seeing improved facial profiles. We are seeing improved sports activity because muscle recruitment is improving when you have a good function. This is another patient that came to me. She had the 6 front teeth veneered. She said the dentist had a really hard time adjusting these crowns. They had to shave the back of the crowns quite a bit. And, she had some TMD symptoms and also just didn't like the shape of her marionette lines and TMD issues. So when we brought her jaw down and forward, we tested it with our orthotics, and then I ended up doing a full lower arch reconstruction on her. Well, the patient told me that because I did 14 teeth on the lower arch, and the previous dentist, the general dentist who was not paying attention to airway and TMD, did just 6 crowns or 6 veneers on those teeth. And the patient told me, she said, that dentist with 6 teeth had a much harder time fitting them in my mouth than you did 14 restorations. Why is that? And that's because I think he was fighting against physiology. He probably invaded the path of closure of that mandible. He was in the, when he added a little bit of a thickness to the back of those teeth. But then when I had her in a physiologic rest position and established my occlusion in a more physiologic position, we didn't have any problems. So these are the cases, that I go back to history, getting a history from the patient, doing the right diagnosis. It's all about diagnosis. That's the only thing that will save you and your practice long term is to get to know your patients and prevent disasters in your practice. There's different ways, that you can change the mandibular position. Sometimes, we use removable orthotics all the way to the left. Sometimes the bones, just the size of the bones, there's a skeletal issue, so patients will need surgery to correct the alignment because there's only so much that you can do by decompressing the joint and keeping the muscles in the right position. So sometimes surgery is needed, sometimes orthodontic movement is needed with Herbst devices, and sometimes we just do it with myeliner. So there's different ways that you can achieve the same goals. The pictures on the right side are patient after actually jaw surgery. So she was placed on a Herbst device for 8 weeks, and with myeliner holding the patient in that position, she can actually chew and function during the day. So that's how we were handling that case. So again, back to anatomy, the teeth are a guidance system for our jaw position. It's because of the cuspal grooves on those teeth and their communication with the periodontal ligament, which is through the trigeminal nerve directly connected to our brain, that patients are in homeostasis if there's balance between their muscles, joint, teeth, and central nervous system. And if this balance is thrown off with one tall crown or one heavy, occlusion on a two-surface filling, these patients will learn to deviate from that nociceptive stimulation, and it can actually change the trajectory of their opening and closing of their mandible. So they can come and blame you for triggering their TMD symptoms. So knowing that these patients were predisposed to it is very important. And that's why we want to make sure that, when you are doing ortho on a patient that has TMD, or you're planning to do restorative on a patient that has signs and symptoms of TMD, it's really a good idea to test drive the bite and either with an orthotic or with myeliner orthotics, and make sure that the patient can function in that position and they're asymptomatic and happy. And a lot of times airway opens up too, especially when you advance the mandible forward and expand the maxilla. The reason we made myeliner segmented is because of mandibular flexion. And I know osteopathic physician, myofunctional therapists, they really appreciate that, allowing the muscles and the movement on the two sides of the body to be independent. So because the mandible flexes, that's why we never place a crown from 18 to 31. We want to make sure that there's movement and function there. So that's why myeliner is in segments, and it also allows for a better design on the occlusal table when we have lingually inclined posterior teeth and anterior crowding. When you want to have a one line of draw for a device, it just the designers have to overcome a lot of undercuts. So the occlusal table gets really wide, and that can stimulate the tongue, and patients might clench and grind actually more because they're losing tongue space. So by making it segmented, using 3 lines of draws per arch, we can make that occlusal table a lot smaller and making these really functional. So we do have a FDA clearance for TMD and migraine headaches, and a lot of our providers have been billing these under medical because those are medical conditions, TMD and migraine headaches, and that's why we went after FDA and got that clearance. So it's billable to medical, and again, we went through a lot of the safety protocols. If you like to read more about this, you can go ahead and scan this article and see how we are treating really complex occlusion cases with a physiologic approach, opening the airway, opening the relaxing the muscles, kind of like combining neuromuscular with CR, with airway dentistry and complex restorative dentistry. So this is, please go ahead and scan that. If you can't scan it right now, you can go to myeliner.com, and on the right-hand side, you'll see research. Click on that, and it will take you to this page. There's 30 different scientific articles use a citation here. So, and it will just interconnect how TMD, occlusion, and airway, and posture, and athletic performance is all interconnected. It's going to be a great reference for yourself and your patients. At the end of the day, with what I like to emphasize on is that in my practice, we saw increased satisfaction from patients. We saw increased compliance when we are taking these physiologic approach, and patients are really appreciate it. It really sets you apart from other general dentists that they have been to that really didn't look at these conditions. It really helps with the production when you don't have to have a repeated dentistry, and it will really increase your decrease your chair time, liability, and strain. So I like to take some questions at this time, before I continue on, to see if there's anything in particular you want me to focus on.
Wonderful. Thank you so much. And yeah, there are a couple questions. So we'll start with the ones that are in the question and answer segment. Can myoaligner be used prior to or during MARPE to preserve improved muscle balance obtained specifically with treatment with the mandibular orthotic?
Yes, as long as you're not moving the teeth that the myeliner is sitting on, you can use it for different for that procedure. So if I understand the question, you want to stabilize the mandible with a myeliner and then go ahead and expand the maxilla with MARPE. Yes, that's one option. A lot of our doctors that use a removable device like ALF or DNA, that's what they do. They bring the mandible in the right physiologic position. You can use a leaf gauge, you can use a TENS bite, you can use a phonetic bite. I know Dr. Gelb really likes the phonetic bite. Those are all really good techniques to basically land your mandible to a physiologic position, and then you can expand. And I find out that, especially with like a cross bites, when you're jumping that cross bite, having a device like myeliner makes it really easy, because then you can you don't have to worry about the teeth colliding during the day and reversing your expansion on top. You can really, and sometimes the designers will go ahead and actually put those design those buccal cusps flat, so you can jump those cross bites, either posteriorly or anterior cross bites. If you're treating a class 3 case, sometimes these mandibles have rotated and come up and trapping that patient in a class 3. You can drop their jaw a little bit, open the video slightly if that's the indication, and then jump that cross bite over.
So you would fix structural issues first, then treat cosmetically? And what about tongue ties?
Yes. So what I said was just the preparation phase is about 3 months. In that 3 months, I'm learning more about the patient. I'm looking at the structural issues. I am sending him to myofunctional therapy. We can release tongue ties during that time. But, if I release tongue ties, if I know that the patient has room in the maxilla, sometimes we have to expand. If you have a really narrow, high vaulted palate, you have to expand a little bit for the patient to function. The positive feedback we get from myofunctional therapists is that when the occlusion stabilize, these patients graduate from myofunctional therapy faster. They do better. Why? Imagine you have a deep bite, bicuspid drop off, deep bite, and every time this patient swallows, for their back teeth to come together, they have to really retract and close their video. Now, if you do like a 2-segment myeliner and give them a lift on that bite, every time they swallow, they will be in that physiologic position, and you can see that the tongue will float nicely, and all the muscles of the neck are happier. So yes, we basically test drive the occlusion with an orthotic, whether it's myeliner or the other type of orthotics that I mentioned.
Can you explain how the mandible flexes, especially in area of posteriors?
Yes, the mandible, just the bone of the mandible flexes because of the pull from the medial pterygoids and other muscles. So when we function, it's flexing a little bit. And actually, I have a reference to that article for mandibular flexion. There was research in the 80s done on implants, And the implants, the all-on-4 or implants, were placed more in the posterior section of the mandible. And after a while, these implants will just come out of the bone. So I found one research that showed mandibular flexion, and that's why the implants are mostly placed more in the bicuspids and anterior section of the mandible that doesn't have that much flexion. So the temporalis muscle and the medial pterygoids, they all contribute to that flexion.
Do you ever need to reduce the VDO rather than increase it?
Rarely, and that's usually with the anterior open bites, and that's a really tough skeletal. Those are the toughest cases. Yes, that the posteriors actually need to be intruded. But majority of our cases with the narrow jaws these days are retraction, class 2, division 2, or class 2, division 1 cases. They work really well with by relaxing the muscles and bringing the mandible down and forward.
Are there cases when the patients continue to have long-standing muscular tension and status post-occlusion change after work is done?
It is definitely possible, especially if airway was not addressed. Some of these patients continue to clench. So that's something that I look at. With my neuromuscular background, I do measure muscle activity and I establish a relax so I can see EMGs before and after. And there's a few companies out there that make really good instrumentation for you to establish muscle activity. We're going to talk more in depth at our course about that. But with just a few electrodes on the face, you can measure the masseter, temporalis activity, digastrics, and then after you take your bite, you can put your bite registration in and then measure muscle activity. So you can see how the EMGs improve and then you use that as one of the data that you establish your bite.
What about anterior open bite and how to do posterior intruded? Will expansion work?
Yes, expansion of the palate, yes, would work, and then intrusion, rotation of the mandible as you decompress. Yes, there's cases that you can close the anterior open bites, but those are really usually very hard, and sometimes it has to be done surgically.
So that leads to the next question. What cases are considered contraindicated?
Contraindicated. Contraindication is usually, and we have that in our forms because we went through FDA, so we had to have really good forms for our patient care instructions. Contraindication is usually periodontal instability for patients. At the end of the day, this is a removable device. If somebody cannot take a device in and out, that's contraindicated for it. Mostly periodontal, a lot of decay, patient that doesn't have good hygiene. But most cases that you need to change the video, you can do it. And it does no harm, it's a device that you can just use temporarily. Basically, I use it both as a diagnostic tool and as a treatment tool. Again, today I told the patient that too, because he has a lot of tinnitus. And I said, this is our diagnostics. So it's reversible. It doesn't do any harm. You just wear it for a short time. If it gives you healing, then that means we're headed in the right direction. Because this type of treatment is this type of problem that we're dealing with, airway, TMD, occlusion, is multifaceted and multifactorial. So, by just fixing one thing, we cannot promise to change everything. And that's why we have that exam again. I go back to the exam, and I'm going to emphasize a lot on that during the course too. What to ask for, what signs to look for, so you can, and the expectations that you need to set for the patient. After years of grinding, clenching, having all this, you cannot just do one magic procedure and reverse everything. Postural adaptation, you need to, yes, it's all connected.
Do you think that cosmetic dentistry creates further issues for airway troubles or just causes problems on the restoratives?
Yes, cosmetic dentistry can cause airway issues if they're not paying attention to that. Definitely, just like retraction orthodontics can cause airway issues. A lot of and I heard, we work with some dentists in other countries. In some other countries that cosmetic veneers, even 20-year-olds go and have veneers done to have whiter teeth. Actually, they're making it illegal for dentists to do full arch cosmetic cases because it is causing a lot of problems. That's why you don't want to do anything that's not reversible. Test drive it, make sure that you're headed in the right direction. And that's why what I do, we used to do diagnostic wax ups and put it on with a fixed orthotics. Now I use my aligner to test drive it and make sure that I'm both me and my patient are ready to go to the next phase. It's very
I
important.
love how you invented the solution for your own problem. That's so amazing. And then you're sharing it with everybody because I can't
Thank you.
imagine going back to those times. Like, can you imagine not having the myoaligner as a resource tool?
Thank you. Yes, and I've gotten the same feedback from a lot of our my colleagues. It just makes things simple. And but it's this is 3D design right now. It's being milled. We need more accurate 3D printing technology, better materials. So it's still in the early phases. Kind of like how ceramic crowns, or zirconia crowns 10, 15 years ago were, and but we are seeing really good results, even in these early phases of technology. I remember Dr. Ira Shapira, one of my mentors, he said, when I brought this up several years ago, he said, dental technology hasn't caught up with your vision yet. So be
Right.
patient.
Well, the key word is yet, one of my favorite words. So it was a nice comment I'll share with you. It says, thank you for doing this amazing work. Your patients are extremely lucky. And I agree. And that's why we want to share this for everyone to apply to their patient and have that comprehensive care. You basically have the solution for complex problems. So it's part of our platform. And we're really, really so proud to have you as part of our faculty. So I think that's all the questions for now that are popping up. Did you want to continue on and then we'll go back to some more questions?
Sure, I can share more cases. If
Sure.
you just give me 1 second, if you want
Sure.
to do any housekeeping stuff, then I will go ahead and just open my conversation. Yeah.
Well, let's see, because I don't want to, will it take you more than 30 seconds?
No,
Okay.
just
Okay, then yeah. So then we can be patient and just wait. There was a question. I know you're good at multitasking because we have these kind of
okay.
meetings.
Mhm.
Is someone asked, how can you be a provider here in the Philippines? But we can have a broader question. Is this available outside of the United States? Where is this currently available, the MyoAligner?
Currently, US and Canada.
Okay, so not yet.
Yes. So I like to cover what we're doing with aligner therapy.
That would be wonderful.
Yeah. Okay.
Okay, so we have your screen shared.
Yes. So
Yeah.
I wanted to show you firsthand how, look at this case, really big overjet, retraction. This is the patient's own hands, not my hand. So he's putting his myeliner in, and you saw that overjet. And by just changing the occlusal surface on these, and you can see his front teeth, he has veneers. So at some point, he just hated the way his worn down, discolored teeth look. And when he removes the myeliner, you can see how his jaw retracts. So we're doing this technique. We're basically taking what we call a myobite. You don't have to do myeliner. It's just a bite registration that is in a happy position of the muscles and a good joint position. So we take that bite registration and then we've build the best device to that position. You can see how his overjet is eliminated, mandible decompresses, comes down forward. Obviously, it relieves the pressure on the TMJ joints and as well as opening his airway a little bit. So then we go, and sometimes we kind of like what we're doing is starting our ortho with that position. So you can see there's posterior open bite where my myeliner used to be, and we are tripoding and holding that position and moving the teeth to that. With this one, again, this is in a very early stages of this technology, basically doing more of a physiologic approach to aligners. And what we're doing is using some occlusal ramps, not on the teeth, on the aligners to basically hold that myeliner position and before we go to phase 2. So one might ask, why should I do an orthotic first and then go here? Why can't I just take a bite and do my ortho? Because during that 3 months, the body gets adjusted to it. The neck adjusts, and as we change the neck posture, the jaw alignment changes too. So I kind of I like to land predictable position for my mandible before I start my ortho. So this is how we're applying it in ortho. Basically, we're starting with a good physiologic jaw position, not a pathologic position. And a lot of times, I'm sure if you're doing a lot of clear aligners, you start with 25, 30 aligners, then you'll notice that the ClinCheck does not match what you're seeing in the patient's mouth. It's not because the teeth did not move, because the teeth still fit the aligner. It's because the rug underneath moved. It was the mandible that moved. So as you're widening the space in the upper arch or that garage of the maxilla, the mandible is now moving to more of a physiologic position. And that can be a good thing and can be a bad thing, because good thing, yes, if they had TMD symptoms, most likely it will cause some decompression and be a good thing. But if you don't know where you're going, and just the technician, behind the scenes is moving your teeth and not taking into consideration that the mandible will move too. If you have a slight kind of like canting of the mandible and this patient had a hidden TMD symptoms, that's when your jaw gets stuck in the middle of ortho treatment. So it's more predictable, and that's why you have to do 20 more aligners, 30 more aligners. I've done up to 100 aligners, in my lifetime, for one patient to finalize my occlusion. So when you actually take the orthopedic into consideration, every time we do orthodontic movement, we have to expect some orthopedic movement of the bones underneath too. So this is how it can come in handy in aligner technology. And I think I showed you.
Just a couple questions on
Yeah.
that part. We might as well just interject here. Do you perform any arch expansion before you use the myo-aligner?
No, arch expansion is usually for the upper arch. Myeliner usually captures the lower arch position. We have used myeliner in combination with DNA or ALF because on patients that have missing bicuspids. So if you have a device that is going to create spaces for the bicuspids, sometimes we use the myeliner as a daytime solution. So it holds the spaces, it's aesthetically nice for the patient, and especially if you have a bicuspid drop off, their jaw during the day does not retract back. And I have slides of that. I think there's a slide of that on myeliner.com. If you go to how it works, you can see one with a gap. So actually that was Dr. Tennant. She might be on the call. And she had quite a bit of expansion done with DNA, but during the day when she occluded, her jaw was uncomfortable, and she just hated the fact that as a dentist, she had these big gaps. So we use a myeliner during the day, and then she took it out and then did the DNA at night. Or it could be, if you like to, you can also cement it on and then do your expansion. But it doesn't do any expansion. It just basically fills that intraocclusal space to give you a good occlusion at that moment.
Can you use a myo-aligner on children with TMJ problems to deprogram prior to starting expansion? And if so, what age could you start?
So Myliner was FDA approved for adults 18 and older. So as a company, we recommend that it's used for 18 and older. At the end of the day, the dentist is the decision maker. It's their provider, so they can decide if it's a good choice for their patients or not.
Have you used myo-aligner on children?
I have used it for 16, 17-year-olds that had full dentition and had TMD issues. Yes.
Are
But I
all of your
wouldn't use it
cases, I'm
on,
sorry.
I'm sorry, I wouldn't use it on somebody that is their dentition is changing. They have to have full adult dentition.
Are all of your cases seeing a myofunctional therapist?
Pretty much, yes. We either do some type of laser, airway, or myofunctional therapy with these tough cases, yes.
Okay.
It's a great complement to the treatment.
So let's carry on. This is great. Thank you.
I call the tongue the built-in retainer.
Mhm.
It's very important that the tongue function is correct.
Did you
Well,
want to show, I know I stopped you in the middle of your presentation. Did you want to go back and then
oh no,
see if
it's
there's a question?
5:55. I just closed it. Yes. So
Okay,
yeah.
okay. So there are some questions that we have that people submitted earlier. Let's see. Is failure of restorative dentistry due to poor airways?
I think airway plays an important role. Yes. It's usually, especially if things are breaking and cracking, if it's not an open margin that caused the recurrent decay, yes, it's function. It's usually function. And we cannot stop the function by just throwing a night guard at these patients. Most night guards actually make the airway issue worse because they're so bulky and they create a ramp for the mandible to even slide back further. So I don't really like night guards for airway patients.
Okay. And do you advise pre-MAD delivery, MAD delivery, or TMJ exercises? If yes, which ones, if you can share?
Yes, I usually for my MAD devices, I take a myobite. I relax the muscles, let the mandible land to come down and forward, or if it has pitchy or roll movements because of poor occlusion, I want the mandible to land to decompress more on the compressed side. Then I put the occlusal ramps there for the MAD devices. So it's very important. You can do that with exercises, you can do that with different ways to get those muscles relaxed and release. With Olftens, I can achieve that result in 20 to 40 minutes, so it saves me time when we use Olftens, and that's something that has been FDA cleared through Myotronics. If you want to look that up, it's an ultra low frequency electroneural stimulation, so it's not like a regular TENS machine that you buy on Amazon.
And for clinicians realizing they need a more comprehensive approach, what foundational mindset or skill shifts should they start developing today to prevent failure tomorrow?
Recognizing the problem, the signs and symptoms, basically a good diagnosis I think, is the key. Understanding the signs and symptoms that are pre-existing in the patient, even if they don't have symptoms, is going to really help the longevity of your restorations and at least having a conversation with the patient and using other devices to maintain a good physiologic position, even maybe at night to protect them. I like a MAT device much better than a night guard.
And just it says, just here a nice comment. What an honor to be in your presence, Dr. Motlagh. Whole health dentistry is my mantra. Still learning after 30 years. Airway is everything. Agree with the night guards. Thank you for the beautiful knowledge. Love the myobite. Just a little kudos to you.
Oh,
So thank
thank
you,
you.
Dr.
That was so
Sen.
sweet.
Yeah, that's really nice. So let's talk a little bit about this course and why we are developing it and why you want to. Now I think people know why you want to share it, but maybe just give us. This is your baby, so I'm going to have you present this because only you can. Yeah, you know every slide that you put so much detail and thought into. That what will people get once they take the course? What should they expect after they take your course?
I want them to be able to, the course will prepare them to do a full mouth reconstruction, basically, with different techniques. So for after day one or the pre-learner, the way that we designed the 90-minute pre-learner was to emphasize a little bit on who is a good candidate. So I want them to start looking for those patients in their practice, which I know there's plenty of them in the practice, if you're looking at the right signs and symptoms. And then the day one will be basically looking all the diagnostic tools, looking at the forms that we need for complex cases, and planning the case right. And then day two will be how to deliver an orthotic, how to set the stage for preparation, for delivery of restorations, and for equilibration, coronoplasty, basically full mouth reconstruction. In a nutshell, I want them to be able to, by the end of the course, I want them to have a patient or two ready to go into orthotics in about 3 months. And then when they come and take the hands-on course, we had the next one is in March 15. The hands-on course, I'm actually delivering a myeliner so they can see me, and then they can implement the same techniques for the full mouth. So by the end, my goal is for them to start 1 or 2 patients as they go through the course, do the phase 1, and then once finished the course, start a full mouth on them.
So I just also want to talk about the course format. So we have it where it's a live virtual experience. Day one is February 27th. Day two is March 6th. This will be recorded. So if you can't make the whole entire day, you will get the recording shortly after, and it'll be available on demand. But there's a day 3, which is a live in person. So can you tell us a little bit about that? That'll be live streamed and in person. So tell us about the day 3 of this mini residency?
Yes, day three, we're offering it four times a year. And it's going to be here in Portland. Our headquarters are in Portland. Day three, we start by doing a patient workup. Basically, it's kind of like a combination of day 1 and 2. We're going to go through a diagnosis all together with different colleagues that are going to be there. So we'll do a live patient workup. And then in the afternoon, we usually deliver the restorations or myoliners. We'll do some fine tuning. We talk about corneoplasty, fine tuning the bite. Sometimes if you have time, we demo a laser. We have a Deca laser in the practice, so we can demo our airway technique and also a tongue tie release. But it's mostly going to be kind of like in the morning will be a patient workup, and in the afternoon will be a delivery.
Wonderful. And for those who say are East Coasters and don't want to travel to Portland, it will be live streamed, correct?
Yes, it will be live streamed. So we have, yeah.
Wonderful. Well, I'm so excited to add this. And also, let's say someone isn't an airway focused dentist. How would this course be good for them too?
If they're doing any restorative dentistry, yes. Yes, if you're placing even a single crown, like you saw in that case that I showed, 2 crowns ended up with failure, and actually a full mouth reconstruction in my practice. That if that dentist had the same training, they would have probably been able to offer the patient the same level of care. And $60,000-$70,000 later, it would have been great for the practice too, instead of losing that patient and refunding them their money. So even if you do single tooth dentistry, I think it will help, and it will help you do more complex cases, especially with the segmentation of the orthotic that we do. You can do quadrant dentistry because you still have the rest of the bite stabilized, and you can just remove that one segment and maybe place 4 onlays on the posteriors, restore those, and then bring them back and do the rest. The complexity with these cases comes from losing the bite, using that maxillomandibular relationship. But when I teach you to stabilize it first, test drive it, and then gradually just move that, turn that into more of a permanent restorations, it makes it very easy. And that's why we call this course a simple solution to complex problems.
Absolutely. And I also love that you have the increased patient satisfaction and increased compliance. So you're already covering 2 barriers, and that leads to more patients, I assume. So we're really excited about this course. Again, it starts February 27th. We are offering 20% off. The code is in the chat, but it is AHSMM, as in Maryam Motlagh 20. So hope you take advantage of that. And it will also be available on demand, as we mentioned. I also want to discuss, it is still Children's Dental Health Month. We're so thrilled about that. So we are offering 20% off of all our pediatric coursework, and we are offering 10% off of all our other adult courses as well. So hopefully, if you're on the fence about whether to start or you need a sign, this may be your sign to come and join us and be part of our alumni. You will get also recognized on our Airway dentist locator, which will also get you new patients. And we're thrilled to announce Airway Palooza. Dr. Motlagh will be on the podium for that one. That's going to be in April of 2027. And we're thrilled and honored to combine conferences with the Breathe and Thrive Symposium this year. So that'll be April 22nd through the 24th in Fort Lauderdale on the beach. We're going to have a luau. Everything's under one roof. We have the top speakers. I can't wait to announce our speaker lineup. Everyone's going to be thrilled. And we're also introducing Myopalooza, which will be on the Thursday, April 22nd, with the top Myo speakers. So we're really happy to bring this all under one roof and celebrate. Actually, our theme is standing on the shoulders of giants. So we're paying it forward. So we're going to also acknowledge the giants and our mentors from our mentees. It's just this big circle of giving and giving. So it's going to be fabulous. We are offering $500 off. This is our deepest discount. It will sell out because both conferences have sold out for the last 2 years, and we do have a 450 capacity. So we know we will hit this. We're going to hit this early. So if you're on the fence, we also offer financing so you can save your spot. And this will be the deepest discount up until February, and then we will have price reductions, but not this steep. So hopefully you'll take advantage of that, save your spot, and we'll see you for that. And also, we would love to see you in April at my friend Dr. Gerald Simmons. He's actually on the AAPMD webinar. You can jump to that one right after this. But he has a wonderful, fabulous conference, the SEC conference. So you can use the QR code to get a discount and use our coupon code. AHS will be there proudly supporting that. And wait, there's one more conference I do want to add is the AAPMD conference is in May. So go to their website and look under the collaboration cures, which will be in Pittsburgh this year. So take a look. They're having a new format, and we will all see you at these fabulous events. So let's go ahead and do our spin the wheel and offer our pediatric foundations of health course to one lucky winner. Let's see who gets it tonight. Okay, Brian Halstead, congratulations. You're a lucky winner. So we will reach out to you. And I wanted to thank you so much, Dr. Motlagh, for all you've done. You've really propelled dentistry forward. You're going to be the giant, one of the shoulders that we're standing on. Building pillars of changing and being the change you want to see. I'm in such admiration of your work and just your graceful heart. So thank you for all you do. And again, we're so proud to have you on faculty. And everyone, thank you so much for joining. Again, we're here as long as you're here. So we're here to help spread the awareness. Please share with your colleagues. And Dr. Motlagh, I'll let you take us out with any kind of inspiration or anything you want to do to wrap up this fabulous night.
Thank you. It's been great to be part of this community. I'm really excited. And you're covering so many areas from pediatric to adults, to now to prosthodontics. I think, that it's a one shop stop, so people can get a lot of information. One-stop shop, yes, can get a lot of information from all these great instructors, and yourself too. With you're just such a gracious person, and it's so nice to be involved and be here and share and learn from each other. I'm really excited about that.
There you go. Perpetual students all our way. So thanks, everyone. Have a great night, and we'll announce our upcoming conversations soon. Have a great night, everybody.